Hello everyone and welcome again to our channel Human Anatomy by Doctor Ankit. I am Doctor Ankit and welcome to our most comprehensive anatomy MCQ series over here. We launch videos daily around 8 p.m. on YouTube, targeting mainly the NEET PG and the INICET. And happy to announce that week 1 has been over and we are done with the upper and lower limb. We are into this week 2 and today is the 4th session of the Neuro anatomy MCQs. So without wasting any further time, let's start with the MCQ over here. The MCQ says that a 54-year-old man is brought to the emergency 30 minutes after being hit by a car while crossing the street. He had a left-sided tonic-clonic seizure and one episode of vomiting while being transported to the hospital. So there is a 54-year-old man and there is a history of an RTA, road traffic accident. He had seizures and vomiting. On arrival, he is not oriented to person, time, place, or person. Examination shows flaccid paralysis of all the extremities. A CT scan of the head is shown over here. This patient's symptoms are most likely the result of a hemorrhage in which of the following structures. If you look at the CT scan also, you'll see some opacity inside the brain over here and particularly in these areas if you focus. Now, there's a history of RTA, that's very important. There is a history of RTA, road traffic accident. And then he's having seizures, vomiting, and now paralysis of all the 4 extremities. And you're seeing the opacity on the CT scan. Now, here, the options are into the ventricular system, between the dura and the arachnoid, that is they are asking for the subdural hemorrhage over here, between the skull and the dura, that is the epidural hemorrhage, inside the parenchyma, normally happens in the basal ganglia region when there is increased blood pressure of the patient normally, or between the arachnoid and the pyometer, that is actually they are referring to subarachnoid hemorrhage. Now remember over here that in the subdural sort of hemorrhage, the picture is more of a concave or convex type, right, and probably located just deep to the dura on the sides, or it might include one half of the skull. The epidural hemorrhage, it appears like a biconvex shadow, and obviously it's arterial bleed and quite emergency situation it is. On the other hand, the SDH, the subdural hemorrhage, is sort of a chronic bleed. Why? Because the reason is normally rupture of the veins. Now into the cerebral parenchyma, it can be, but it doesn't refer to history of RTA. It normally can happen anytime and normally appears around the basal nuclei or the basal ganglia region. While you talk about the subarachnoid hemorrhage, now here the point over here is that most common cause of SAH or subarachnoid hemorrhage is the trauma, as you can see. And in the subarachnoid hemorrhage, what actually happens is that the subarachnoid area is where we have the CSF, cerebrospinal fluid, right? And these are located inside the cisterns. We have the subarachnoid cisterns. So whenever there is any bleeding in the subarachnoid region, what actually happens is the subarachnoid also have the important arteries which are supplying the CNS or the brain. Now, when those arteries will rupture, they will accumulate the blood, or the blood will start to accumulate in the subarachnoid cistern area, is what we are seeing over here. Therefore, it is most probably a picture showing us the subarachnoid hemorrhage. Therefore, we can go with the answer between the arachnoid and the pyometer. Here's an image showing us the subarachnoid space over here, right? And you can see the aneurysm that might have ruptured. So there are multiple causes of subarachnoid hemorrhage. And do also remember, mainly in subarachnoid hemorrhage, what actually happens is that though trauma is an important cause of the subarachnoid hemorrhage, but basically it is also due to the rupture of the berry aneurysms. What are these berry aneurysms? Actually, if you look at the anatomy of the circle of Willis, then there are places where you have the junction of, say, anterior communicating artery with the anterior cerebral artery, right? Then you might also have seen that the posterior cerebral artery is joining with the posterior communicating artery. So areas like junction of anterior communicating or the posterior communicating artery, these areas are where the aneurysms might develop, as one is shown over here. Now, when there is increased pressure, those aneurysms might rupture, and there they lead to subarachnoid hemorrhage, as we are seeing in this particular case, right? Let's move on to the next one over here. The next question asks us that there is a 71-year-old, an old man over here, and he comes to the physician because of involuntary shaking and gait abnormalities. He also reports a depressed mood and diminished smell and taste. So there is overall decrease in the overall mood and the overall attitude of the person. Examination shows what? There is a shuffling gait with a resting tremor in the left hand. So in one hand there is resting tremor. Resting tremor means while on rest, while not doing any activity, there is some tremor that you can see, right? That is normally seen when? It's also known as a pill rolling tremor. What is that also known as? It's normally also known as a pill rolling tremor, okay? And that is a pathognomic feature, you can say, of a disease that is known as a Parkinson's, right? We have Parkinson's disease, which is quite commonly seen in the neuro wards. Now, and also rigidity in both arms is what the other point is referring to. The patient most likely has structural changes in which of the following labeled areas of the brain. Now, we should be knowing from a basic knowledge of physiology that the Parkinson's disease is when there is a problem in the dopaminergic fibers, which mainly arise from the substantia nigra. Substantia nigra is actually a part of the basal nuclei or basal ganglia. But where exactly is this substantia nigra located? It is located, or anatomically it is located where? Anatomically it is located in the midbrain, right? And this is what we have to identify. If you look at this image, and let me just zoom it a bit, we can easily recognize this is the pons region. Below this we have the medulla oblongata. Okay. Now above the pons we have the what? We have the midbrain. So this area is our midbrain, and this midbrain, you can see this a slightly darker area. That area, option B, is the substantia nigra. Answer is our option B. But if, just for the sake of completing all the other options, first of all, let me just point out it is a coronal section so that there is no doubt. What is option number A over here? What is option number A? It is surrounding the third ventricle, and it is basically our diencephalon, mainly the thalamus over here. Option number B is our substantia nigra, already quoted. What's option number C? Option number C over here, which is just deep to this, let me point out this as the LV is the lateral ventricle. So option number C over here is our caudate nucleus, again a part of the basal ganglia or basal nuclei. Option number D are the projection fibers known as the internal capsule, the white matter fibers. And option number E is a part of the lentiform nucleus, could be a putamen over here. Again, we are mainly referring to the basal ganglia. Now, considering all of this, we know the answer. We have already quoted out. The answer is option number B over here. That is the substantia nigra, anatomically inside the midbrain. Okay, let's see the next one. A 67-year-old man is brought to the emergency department 1 hour after a sudden onset of left-sided body weakness and difficulty in speaking. So this left-sided body, 67-year-old, 1 hour history, left-sided body weakness. So in the brain, the problem should be on the right side. Understand this part, okay? And difficulty speaking. Now, speaking, we all know, is basically done by the muscles of pharynx and larynx, all those. Let's see more of points in the question. His BP is 150/87, slightly high, on the higher side, obviously. Examination shows the deviation of the tongue to the right. A very important point, deviation of tongue to the right. Now, the tongue is deviating to the right, right? Then there is which-sided hypoglossal nerve injury. Remember, the tongue licks the wound. So when the deviation of tongue is to the right side, it is a right-sided hypoglossal nerve injury. This comes from where? This comes from which part of the brain or brain stem? It comes from the medulla oblongata, 12th nerve, right? Left side body weakness, again it is saying its problem is on the right sided, right? Difficulty speaking, why? Because pharynx, larynx, there might also be involved, or the 12th nerve, tongue is involved. Let us see more of it, of the question. So deviation of tongue is to the right side, left side hemiparesis, already told, and decreased proprioception on the left side. Now see, if you look at the brainstem structures, let me tell you the structures in the brainstem which are more medially located. What are those? Remember that. It's a very, very, very important. On the medial side, with the letter M over here, we have the motor nerves, we have the motor tract. Now, 12th nerve is a motor nerve, and motor tract, we have the corticospinal tract. We also have the medial lemniscus, which basically takes our vibration proprioception. There you can see decreased proprioception as well. So it's all of a medial aspect. It's all of a sort of medial problem. Okay, so you have motor nerve, you have motor tracts, you have medial lemniscus. They are all lying on the medial aspect. What else can you see? Sensation is to pinprick and temperature is intact. Why? Because they lie on the lateral side. This is spinothalamic tract. S for spinothalamic, S for being on the side, on the lateral side. The patient condition is most likely caused by occlusion of which of the following labeled vessels in the schematic overview of the arterial system of the brain. First of all, we have to make a diagnosis in our heads. It is probably medial syndrome. Why? Everything which is being involved is present medial. So we are dealing some brainstem syndrome which is lying medially. But which part of the brainstem? Is it midbrain, pons, or medulla? They are giving you a hint. It's a 12th nerve involvement. Now this 12th nerve is located where? Medulla oblongata. So it is a medial medullary syndrome. That is our diagnosis. Which side? Right sided medial medullary syndrome. So this body is affected on the left side and the right 12th nerve is involved, so problem in the tongue of the right side. Now medial medullary syndrome, which artery will supply it? Well, let me tell you over here. See, what actually happens is, we have this foramen magnum, okay? We have this pair of vertebral arteries entering, right? Now just imagine this area, this is our medulla oblongata, right? Above it, what we have this thick pons over here. Just try to imagine, okay? Now coming back to the artery, this is a vertebral artery which enters, and then at the junction of medulla and pons, both the vertebral arteries, they meet and they form which artery? Basilar artery. This is vertebral artery, right? So vertebral artery in the region of the medulla oblongata is running which side? Lateral side. And then basilar artery runs on the pontine groove. Now it is a medial midbrain syndrome. What will happen now? We have to understand, vertebral artery will give branches which are going on the medial side, and they are the ones which will supply the medial part of the medulla oblongata. And these over here are basically which arteries? These over here are anterior spinal arteries. These are the anterior spinal arteries, right? Even we have the posterior spinal artery as well, but posterior will go posteriorly, okay? So we have this. So if you have a lateral medullary syndrome, then we can think of vertebral artery. That mainly causes what? It causes a lateral medullary syndrome. Why? Because this artery is lying laterally. But here, if we think of a medial medullary syndrome, which our diagnosis was already made, then we should be thinking of which artery? We should be thinking of an artery which is around anterior spinal artery. Now let us come to this image. We are looking for an artery supplying the medial part of the medulla oblongata, right? Okay, let us see now. So here we have this whole arterial system is lying over here. What is option number A over here? What is option number A? Let me see it. See, if it is an artery which is coming from the internal carotid, this internal carotid, and this A artery is going laterally, this is MCA, middle cerebral artery. We have anterior cerebral, middle, and the posterior cerebral. Okay, what's artery number B? Artery number B over here, let me just first of all trace from here. So this is vertebral, V for vertebral. This E option is basilar, and this E basilar divides into two B arteries. This artery over here, same over here as B. This is PCA, posterior cerebral artery. Okay. Now what is this D over here? This D artery over here is again a branch from basilar, but just proximal to the PCA. This is our superior cerebellar artery. Superior cerebellar artery. Okay. What is this option number F over here? So option number F again is a branch from basilar, but it is the ICA, anterior inferior cerebellar artery. Okay. Option number C over here, this is the one which is the answer actually, and you can see it is coming from the vertebral on the medial aspect. This is our anterior spinal artery. Answer is undoubtedly option number C. Answer is option number C over here. A very good question. First of all, make a diagnosis, then apply your anatomical knowledge, see which artery is supplying where, what could be the best possible answer. Hence, this is the answer. A 34-year-old comes, so middle-aged lady comes to the physician because she has not had her period for 4 months. It's not, obviously, it's not a menopausal age, but some problem in the hormone. Let's see. Menses had previously occurred at a regular 28-day interval with a moderate flow. A home pregnancy test was negative, so pregnancy negative. She also reports, now see, headaches, recurrent headaches, and has noticed that when she goes to the movies, she cannot see the outer edges of the screen without turning her head to each side. This is a very big problem. If you are a movie buff, why? Let me show you why. See, suppose this is the screen, right, in the hall, right? This is a screen, and these are all the chairs over here. Just imagine these are all the chairs over here, right? Now, if you are sitting supposedly where in this position, say position number A over here, right? So this position, say position number A, and your vision and your vision is scattered around like this, right? You are able to see only this much. Okay, so every time suppose something happens over here or here, you have to slightly tilt your head to right and left. But just imagine for a second, if you are sitting over here, okay, option number B over here, if you are sitting over here, and even your vision is only limited to this is going to be a very serious problem. Okay, so more the more closer to the screen you take your book, your seats, then this problem will be there. So then this question, the history is not able to see the outer edge of the screen. I just recall 2008, around 2008, a movie came, 2008 or around 8 only, yeah, movie came, Jab We Met, right? In Delhi we were preparing for our exams and all, and it was quite a hit movie, and we went for the buy tickets. So we and our friends, me and my friends, we didn't got the ticket, we only got 3-4 tickets in the front row, and that was the only movie which we saw on the front row. It was quite a headache to watch. The movie was very good, so somehow we saw that movie. I don't know, Jab We Met or Chak De India, maybe it was Chak De India, right? A Shah Rukh movie. So we were sitting on the first row. It was very hard. The movie was good. So somehow, but yeah, sitting on the front row is not a very brightful experience. Coming back to the question now. So she is not able to see the outer edges of the screen. The patient's symptoms are most likely caused by abnormal growth of which of the following. So what we have in this question, coming back to the question, forget the movie for a while. I just recall that. I don't know, just somewhere out of the blue. So problem over here is there is menstrual issues, and there is what we call it as there is a tunnel vision, right? So she can't see on the sides. What is it referring to? It's quite a famous question. See, what happens is we have what? Let me take an empty page. We have this, say, the two retinas over here. Okay. Now these are the nasal retinal fibers, and they actually come, and what they do, they cross and they go to the opposite side. These are the temporal retinal fibers, and what they do, they come to the optic chiasm, they go to the respective sides. Okay. What is this area? This area we all know is the optic chiasm. Now below optic chiasm, what we have? Below optic chiasm, we have the pituitary gland. Okay. So below optic chiasm, we have this pituitary gland. Pituitary gland is actually seated over the sella turcica. So below we have pituitary gland. On top of pituitary gland, we have the optic chiasm. Then we have that anti-communicating artery also. That is also an important question. That which artery supplies the optic chiasm? Remember, it is ACOM, anti-communicating artery. We are dealing with the optic chiasm sort of anatomy over here. Now this lady is not able to see the outer edges of the screen. Now see, which retinal fibers, red or blue, which are the ones which are used to see the outside or the lateral side or the temporal side of the visual field? It is the red ones. How so? Let us see. The light comes like this, the light comes like this. So this lady is not able to see from the red colored nasal retinal fibers on both the sides. On the other hand, these are okay, these blue ones are okay. It's sort of okay till now. So problem is where? Problem is around over here. Right? This problem is due to the growth of a tumor from the pituitary gland normally. And mainly it is the antipituitary that leads to our answer as being the adenohypophysis. This is the antipituitary part. So what is this known as? Tunnel vision. Tunnel vision, this is known as, or you can also call it as what? Bitemporal. BT is bitemporal, heteronymous was both his opposite side, hemianopia. This is what we call it as in the ophthalmology, or hemianopsia you can also call it as. So it is a pituitary gland issue, and it is due to the increase in the size of the pituitary gland that it is compressing the middle fibers or the medial fibers of the optic chiasm from below, and they are compressing those red nasal hemiretinal fibers, leading to tunnel vision. And that pituitary gland, why? Because there is problem in the menstrual history also. Pituitary gland, remember, gonadotrophins, and then this issue. If you look at the other options, astrocytes or arachnoid capsule ependymal schwanzell, you are not able to explain it, right? So thank you for making me go back to my memories. Yeah, nice memories. So let's see the next question over here. A 62-year-old is brought to the emergency. Just a second. Yes, 62-year-old brought to the emergency because of a 2-hour history of left-sided body weakness and involuntary urinary leakage. Okay, so left-sided body weakness, meaning problem in the brain has to be on the right side. This much clear. Left side body weakness, left side sensory loss in the body. So hemiplegia, hemianesthesia due to problem in the brain, contralateral side. So left side body weakness. He reports having experienced a similar episode 2 years ago. Okay. Neurological examination shows the left side hemiparesis and decreased sensation. So again left. So we are dealing with the in the brain problems in the right side. The neurological abnormalities are more prominent in the left lower than the left upper extremity. So one thing is involvement of the left side, fine, and lower limb having more of an involvement than the upper limb, second point. Okay, there is some problem with the urinary system as well. He is oriented time pleasant person. Which of the following labeled vessels in the MR angiography image of a normal brain? So it's this image of a normal brain, this MRI of a normal brain is most likely occluded in this patient. Now look at carefully over here, they are showing us the sides as well, right and left. So in the brain we have to look at which side? Problem in the body is on the left side. On the brain we have to look at which side? We have to look at the right side. So in the right side we have options A, C and D. We have options A, C and D. So remove B and D, see. So 40% of the job is done. We have removed 2 options. So A, C and D are there. Okay. Now what do you think? A is which artery? A over here is which artery? A is the anterior cerebral artery, right? C is the middle cerebral artery, right? And E over here, E would be what? E is the posterior cerebral artery. Okay, so we have anterior, middle and the posterior cerebral artery. Involvement of lower limb and problem in the bladder is basically due to what? It is due to the anterior cerebral artery. Let me first of all tell you, answer is option number A. How come? Let us see how come. The thing over here is, if we look at a lateral surface of the brain like this, okay, now this is, imagine the central sulcus, the middle cerebral artery branches, okay, excuse me, just a second, okay, let me just make it again like this. So now the middle cerebral artery, just 1 second, let us give it one more try. Okay, so the middle cerebral artery branches are coming from here, right? Now it is okay, right? Now see, the middle cerebral artery branches are the ones which will be supplying all these lateral part of the cerebral hemisphere, all this, right? Except this superior frontal gyrus area. And this area, if you recall, then if you look at the homunculus of the body, then this is the region of head and neck, that is the trunk and the upper limb. This area is for the lower limb, both motor and lower limb, S for sensory and M for motor. And this area actually is supplied by the arteries coming from this side, which are the branches of anterior cerebral artery. So just imagine these are the branches of anterior cerebral artery. Let us just, for the sake of it, cover it one more time. Fine. So basically it is the anterior cerebral artery which is coming from the medial side of the brain. Right, here you can see in this image, it is coming from the medial side of the brain. It will first ramify the medial surface of the brain, then as it comes over here, it will give some branches both the sides. Okay, on the upper lateral part, or you can see the superior frontal gyrus, supplying the lower limb and the perineal areas, the bladder and bowel areas. That is what is happening to this patient. Basically, they already said that the lower limb is involved more and there is a urinary problem on the left side. So we look at the right anterior cerebral, answer option number A. That's for sure. Right, so that's all for the session. We'll again meet tomorrow, and tomorrow we'll be into the final stage of our neuroanatomy MCQs. I hope you guys are enjoying. Any queries, let me know over here, or you can join our Telegram group. Telegram group also has the same name, Human Anatomy by Dr. Ankit. And also do watch my previous videos on various topics, like we have some interviews with our champions of FMG exam. Go and watch them, very insightful, and we'll be launching more. And the other videos as well, like how to remove the fear of anatomy, how to improve the focus, particularly for the students. That is quite insightful. Go to watch them, and also share this video, like, share, subscribe if you wish, if you are liking that. That's all. See you tomorrow, guys. Bye bye and have a good day. Thank you.